Good evening, everyone. Welcome to Series 137 of the Africa Healthcare Network Fireside Chats. It is my pleasure to introduce to you tonight our speaker, Dr. Antony Ndichu Muiru. Dr. Muiru was born and raised in the Kanyari village in Kiambu, Kenya. He and his family migrated to the US via the visa lottery program, and he has since achieved great success in building a career in academic medicine. He obtained his undergraduate training at the University of California, Berkeley, medical school at Harvard, residency at the Massachusetts General Hospital, and a Master's of Public Health at Harvard Chan School of Public Health and Nephrology subspecialty training at the University of California, San Francisco, where he is currently an assistant professor of medicine. He is interested in improving our understanding of determinants of chronic kidney disease and thus inform the development of effective strategies that mitigate the risk of kidney disease and its long-term adverse outcomes, particularly among individuals of recent African ancestry, those living in the sub-Saharan Africa and the United States. His topic tonight, a very interesting title to it. Is it your postal code or your genetic code? Social deprivation versus ApoL1 risk variance in kidney disease and racial disparities. Thank you very much and welcome, Dr. Anthony.
Thank you so much, Amma, for the wonderful introduction. Good evening, everyone. Such a joy to be with you this evening, coming live from Nairobi, which is very great to be here. So tonight we will be going on a journey, asking a question that is stated on the screen. So when it comes to Black and white racial disparities in kidney disease, what matters more? Is it your postal address? And by that, I mean where you live, your residential address, or your genetic makeup, your genetic code. And by that, I mean specifically ApoL1. So most of the work I would describe this evening is based in the United States where I work. But I think the importance of social deprivation contributing to health disparities and poor health outcomes applies everywhere. In fact, I love to travel. I'm a little jet lagged right now. But no matter where I go, it seems to me that people who look like me, people of African ancestry, are often disproportionately affected by worst health outcomes. And that is nowhere that is more true than in the US. And that's what we'll be talking about today. I don't have any disclosures that are relevant to this talk. So this is the outline of our discussion today. So I'm going to first describe Black and white racial disparities in kidney disease, and that specifically in the US. I'm going to describe ApoL1 risk variants and their association with kidney disease. We'll then discuss the relative importance of structural deprivation. And I'm going to use the example of structural racism and compare that to ApoL1 risk variants in trying to explain the Black and white disparities in kidney disease. Ultimately, I hope that we can recognize that social deprivation, in this example, structural racism, is a root cause of Black and white disparities in kidney disease. And hopefully we can incorporate indicators of social deprivation in our day-to-day activities, whether that be clinical, research, or policy work. So it was mentioned that I am from Kenya, and I'm just going to briefly just mention who I am, say a little bit about myself. So I am the youngest of 5. I can see the one in the middle right there. The beauty of being the youngest child is that one can really sit back and observe the older siblings navigate life before deciding which footprints to follow. And this is our primary school in our village, where my now late mother was a teacher. And I love this photo because of the joy and the memories that it captures when I look at these photos. And so, as I was mentioned, we left Kenya and went to the US. And here is a picture again of my mother. And this is the IGSF shortly after I graduated from nephrology fellowship. And this is some more photos working in San Francisco. And so, before I went to the US, I didn't think much about the US. Growing up in the villages, of course, we saw pictures, but didn't really think about it. And I was young. But when I got there, I did what young people do, which is to fall in love with hip hop. This is, what I think is a voice of our generation. And, I don't know how many of you are hip hop fan, but Jay-Z is the greatest hip hop artist of all time. And I remember when he released this song, which captures what we're going to be talking about today. In this song, Jay-Z's speaking to political leaders, the president and the governor, and he is discussing the social condition in his neighborhood. So he says, there's drugs in our residence. Mr. Governor, I swear there's a cover-up. Every other corner, there's a liquor store. So Jay-Z grew up in New York, and he is describing what he saw growing up. And this applies really to many so-called Black neighborhoods across America, including Oakland, California, where I landed after leaving Kenya. And so what do I mean when I say social deprivation? This is just one definition. There are many, but this is one definition from APA, Dictionary of Psychology. Basically, it's about access. So having limited access to society resources due to poverty, discrimination, or really because of any other disadvantage. In the US and many parts of the world, poor and minority populations, including Black people, often live in socioeconomically disadvantaged neighborhoods. That's what Jay-Z was describing. And the neighborhood context directly affects access to food, safety, education, health behaviors, stress levels, and overall well-being. This is another picture of what I think about when I say, when I think about social deprivation. This is actually from England. This is the picture from The Guardian. And this is here, it's just water ground in England. You look, and here you can see the residential building. And you can imagine people who live here. I would say they're socially deprived because they're constantly being exposed to these toxins. And so that's what I mean by social deprivation, is a neighborhood context in which people live and they get exposed to various things. And I call it social deprivation because it's a man-made problem, and it's often created through history, which is, as I have seen, is a really difficult thing to get over. So as you can see in this picture, this is a historical images. So racial discrimination was legal in the US, as shown in this picture here. But as suggested by these two recent articles, some of these discriminatory languages that are woven into your title deeds, into your home deeds, still have this discriminatory language even today. So this one that says, this premises shall not be rented, leased, or conveyed to occupy by any person that of the white or Caucasian race. So they are, when I say history is difficult to get away from, this is, there are people who own home in the United States that have this covenant on there as part of their title deeds. And this is an example. And of course, you may be thinking, well, that's a thing of the past. And yes, from a legal perspective, the law on the book, you will be correct. This thing called the Fair Housing Act, which was passed actually in 1968. This outlawed racial housing discrimination in the United States. So in theory, you can live wherever you want. However, on paper. However, when we look at the reality, as I mentioned, history is a difficult thing to get over. What this map of the United States is showing is that 8 out of 10 major metropolitan regions in the US are more segregated, more racially segregated today than they were 30 years ago, right? And this is a man-made phenomenon, right? This residential segregation is the sorting of people into different neighborhoods based on their race. This, in turn, provides differential access to better schools, healthier foods, community amenities, economic opportunities, healthcare resources, and many other elements of life. So when Jay-Z is talking about what he sees in his neighborhood, this is what he's describing. And, although I won't be discussing so much about our local context here, you may be tempted to think that this is an American problem. And it truly is a huge American issue, but it's also an African issue, because we too have what this article describes as the ghosts of colonial racial segregation that still haunt us today This is Nairobi, Nairobi and Dar es Salaam. And you can sort of kind of see, if you pay close attention to the built-in neighborhoods where you live, what's around you, who is around you, you can see that racial segregation is not, it's really a worldwide phenomenon and does apply to this context. But today, again, we're focusing on my adopted home, which Jay-Z was talking about when he mentioned this quote. So far you're wondering, well, what does this have to do with dialysis? What does it have to do with kidney disease? Now, this song came out in the early 2000s. I remember very well because I was memorizing the Krebs cycle at the time in undergrad. But fast forward to 2019. This is a news piece from a local news station in California, and is asking the question, why are there so many dialysis centers in Black neighborhoods? On one aspect, you may think, oh, it's a great thing that we have access to dialysis. And that is obviously an important thing. But the question is, what is the distribution of these dialysis centers? And in the US, there appears to be so many dialysis centers in Black neighborhoods. And this is a quote from a dialysis nurse from this article, who grew up in a similar neighborhood that Jay-Z was talking about. And is saying, I grew up in South Central LA, Los Angeles. When I was growing up, there was a liquor store in every corner, as Jay-Z mentioned. Now, there's a dialysis clinic in every corner. So when I was in medical school in Boston, it struck me that most people sitting on dialysis chairs look like me, and I really wanted to understand why. Why are there so many Black people with kidney failure in the US? So now we're going to describe Black and white racial disparities in kidney disease. And this slide is showing data from USRDS, which is, again, to put a plug-in for data, especially data registries, because it gives us so much information about policy, clinical work, and so forth. So the incidence of kidney failure in Black Americans is 3 times higher than in white Americans. And this is, again, is from USRDS annual report. And this is a graph from the most recent data, again, showing the incidence of end-stage kidney disease by race. And I'm going to orient you with this graph. So this is on the y-axis here. This is cases per million. And this is time. So this is data going from 2018. The bottom line with the lowest rates of kidney failure are white Americans. Here is Asians, American Indian natives. Now, the good news is that in the last 2 decades, it's discouraging, but it's rather discouraging how long we have known about these disparities, how much medicine we have in the United States in terms of advanced therapies, and yet we still have these very stark disparities. So these disparities were actually reported 4 decades ago. 1977 was the first time it was documented in a peer-reviewed paper. This was in southeastern Michigan. And in this study, surprisingly, back then, the incidence of kidney failure was 3 times higher in Black individuals than in white individuals. And the authors stated that the reason for the differences is not clear, but noted that racial factors are an important consideration in kidney disease. They did not go into details about what they meant by racial factors. The 2 factors we're discussing today are APOL1 and social deprivation. So now I'm going to transition into talking about reviewing APOL1 risk variants and the association with kidney disease. Now, the discovery of apolipoprotein APOL1 risk variants was truly a breakthrough in nephrology. I remember when I was in medical school and I first learned about this, and I was just very excited that this gene was described. And so, by way of review, I'm sure most of you have heard about APOL1. So we know that APOL1 risk variants arose in Africa, and are exclusively found among individuals of recent African ancestry. So no other communities have this risk variance. As you can see here in this schematic, individuals with no risk alleles here are susceptible to African trypanosomiasis. This is why we think that this natural selection occurred to promote the high prevalence of this APOL1 risk variant. So individuals who do not have any risk variants are susceptible to African trypanosomiasis. Now, having just one risk allele, at least one risk allele, this you protected from having African trypanosomiasis. However, the cost of this protection is increased risk of APOL1 nephropathy for those having two risk alleles. This is what's called the heterozygous advantage. And this is sort of very similar to when we think of sickle cell and the risk of malaria. And you all are very familiar with that as well. So it's the same idea here, where natural selection is promoting a risk allele that unfortunately contributes to risk of another chronic condition. So this is just a picture of APOL1 gene. It's on chromosome 22, and hopefully this is coming out, but this is the two risk variants that we know about. So G0 is the wild type, so it's normal allele. And G1, there's two variants. There's a substitution here and here. And then the E2 haplotype has a deletion in this location here. And this is another schematic here, highlighting a little bit about why we think that these haplotypes, these APOL1 variants, are still persistent in the community. So let me walk you through this. So those who have just normal variants, so the G0, do not have a greater risk of CKD, but are susceptible to both variants of trypanosomiasis, as you can see here. Having just one G0, you're not at a greater risk of kidney disease, but you're susceptible to acute trypanosomiasis. So you can see here, when you have at least two variants, either G1 here or G2, you gain protection from trypanosomiasis, as you can see in this here, but there is risk of CKD. Stated another way, when you have G0, you're protected. You don't have any greater risk for CKD, but you're susceptible to trypanosomiasis. And then having at least two copies, you risk of disease protected from trypanosomiasis. And so when we think about, I mentioned that these variants only found among people of African ancestry. This is a map of the distribution of APOL1 high-risk variants. This, again, remember, you need to have two copies of either G1, two copies of G2, or the compound heterozygous G1 or G2. And a few things I want to point out in this map here is that the highest frequency of high-risk APOL1 genotypes is in West Africa. You see the frequency in Africa is quite low, but you can see that variance over the world, but it's the transatlantic slave trade, where people of African ancestry ended up. So in the American Caribbean, you can start high, that's a frequency of APOL1. And much is found there. So that's one key finding, is that these are everywhere Black people are, basically. But the other key thing here is, and we have been able to confirm with some of the work that we have done here in Uganda and in Kenya, is that the frequency of APOL1 is quite low, as you can see here, right? However, as everyone knows on this call, we have a, good high burden of kidney disease, yet we don't have this risk variance that promote kidney disease. So the question is why? Now, before I move on, I just do want to sort of emphasize that I'm not saying that APOL1 is not important. Absolutely very important. There is no question that APOL1 significantly increases the risk of kidney disease. In fact, some of the earlier studies showed that those who have high-risk genotype, those are having 2 risk alleles, have an associated odds ratio of 17. It's very high for having FSGS and 29 for having high volume. Those are just when we look at in the US. There's one study that I have not quoted here out of South Africa, and the odds of having high VAN in people with APOL1 was, I think it was 89. So very, very high odds ratio. So the excitement around APOL1 is justified because of the increased risk of kidney disease. And part of this excitement really, when I was in medical school and in New York, sort of like several years ago, people started making this very provocative and very interesting statement that we have found a thing that explains the racial disparities that I've described. So in this particular quote from a highly cited paper, the authors claim that APOL1 risk variants account for much of the excess risk of kidney disease among Black Americans compared with white Americans. And you can see this excitement sort of was all over the place. This is sort of a journal club in the US, and APOL1 was featured among the top 10 nephrology stories in 2010, 2013, 2017. And here is one of the very initial papers that reported APOL1 2010, sorry. This is the first author here, Genovese. That's why the variants are called G1, G0, G1, G2, because he's the one who reported them. And you can see, truly, since this paper was published in 2010, this is a graph of straight from PubMed of papers describing APOL1. You can see there's been this explosion of reports describing APOL1. And of course, with the excitement comes the money. So currently, NIDDK has invested over $110 million on APOL1. And this is just a figure of showing what those funds are used for. And most recently, this excitement led to this publication in the best journal we have in medicine of a drug called enoxaparin that is reporting clinical trials showing benefit in people who have APOL1. So I just want to say that it's very exciting to see the amount of investment in terms of money, resources, publication on this variant. So remember, this variant is exclusively found among individuals with recent African ancestry. So on one hand, I'm very excited that policymakers, researchers, clinicians worldwide are paying attention and doing something about this APOL1. I mentioned it at the top that I love hip hop, and hip hop sort of speaks to me. So the good news is that people are investing on this. So good news is we've come a long way. But my concern is we may be going the wrong way. So the bad news is, are we going the wrong way? And this is a quote from J. Cole, another great hip hop artist. So this is about a year ago now. It's a New York Times article hinting at my concerns of focusing only on APOL1. And they were trying to make the point that if you just focus on APOL1, you may neglect other factors. And this is a Nigerian researcher, a Nigerian-American researcher, and a good friend of mine, Dr. Opiemi Olabisi. And I like, he works in APOL1, has done amazing work in trying to understand the biomechanism in which APOL1 contributes to kidney disease. But I like his quote here that, he says that when we focus on variants, that may let policymakers, the politicians, ignore the social and economic disparities underlying the disease. He says we don't want to pretend that biology does not exist. We have to pay attention to this, but we cannot let policymakers sort of just say it's an APOL1 thing and not look at other factors. So let's look again a little closer at APOL1. So this is another study from one of my colleagues, Dr. Carmen Peralta, who evaluated the association of APOL1 variants with incident albuminuria. As you recall, albuminuria is one of the early signs of of kidney disease. And in this study, Carmen compared Black participants with white participants and showed that Black participants in general have a higher odds of developing albuminuria when compared to white participants. And this remained significant after controlling for these other factors. Now, when we look closely at this data, we notice that while the odds are highest among high-risk APOL1, so 5 is greater than 2, the manuscript makes a point that the majority of albuminuria, 78% of events, occurred in Black individuals with low-risk genotype. Yes, APOL1 is important, as you can see clearly on this study, but majority of the events were happening in the low-risk genotype. So let's look at this again. So this is, she also looked at kidney function decline after albuminuria onset. So this is a graph showing eGFR on this column, on the y-axis, and then age of albuminuria onset. And as you can see here, this is white participants in the dotted line here. The age of onset of albuminuria was about 39 for white participants. Those with low risk APOL1 is about 37, and high risk participants, mean age of onset was 34, right? So clearly, high risk APOL1 is bad for you. You have earlier age of onset. And then what we see is that following the onset of albuminuria, you can see that this fast progression of kidney function decline, right? And then this is particularly notable not only for those with high risk, but if you look at this graph, you can see that this slope is also rapid loss of kidney function with low risk APOL1. And so, to me, these results say that the onset of albuminuria heralds a rapid decline in kidney function. And this is particularly notable for those with high risk variants, but also those with low risk variants. And so there's no question that APOL1 is important. It's clearly important, but it's not the whole story. And this leads me to my question. So if the genetic code is not the entire story, we saw that those with low risk APOL1 compared to white participants have a higher rate of progression. Then what is it? Is it the postal code that may be explaining this? So here's just another community-based prospective study. This is the ERIC study that showed that APOL1 was associated with, in the general population, was associated with a more modest effect size of kidney failure. We also know that APOL1 high-risk variants are only prevalent in 13% of Black Americans. So if it's only 13%, it seems unlikely. If you do the math, it's not adding up. This cannot be, APOL1 really cannot be the thing that explains much of the excess risk of kidney disease among Black Americans compared with white Americans. So my hypothesis is that it's social deprivation, for example, structural racism, and that this is really a stronger driver of racial disparities in kidney disease than APOL1. Again, I want to emphasize that I'm not saying APOL1 is not important. It is, but I am hypothesizing that other factors that are socially derived are more important. So the question that in eventually answering, this is current at the moment, is hypothesis. So what is the relative importance of social deprivation, such as structural racism versus APOL1 risk variants, in explaining the Black and white disparities in kidney disease? Why even ask this question of which one is more important? I think that until we identify the most strongest, the fundamental driver of racial disparities, and prioritize these determinants of disease for intervention and innovation, I don't think we'll ever eliminate this racial disparities. So yes, we have to study both, but I think where do we put more of our attention is what the question is. And I already showed you how much attention that we are putting towards APOL1. I wish I can tell you the same about how much we're studying these social indicators of health, and it's not much at the moment. So let's focus a little bit on structural racism as an example of social deprivation. This is a long definition, but I think it's important to go through it. When we say structural racism, we're referring to the totalities of ways in which societies foster racial discrimination through a system, right? Through a mutually reinforcing system of housing, education, who gets jobs, so employment, earnings, benefits, credit, media, everywhere, healthcare, and criminal justice. These issues or these areas intersect with all aspects of society. As you can see here, housing, food access. And when you have disparate access to these resources, that leads to different in health outcomes, as stated here. So structural racism has produced and reinforced segregation, differential access to healthcare, unequal distribution of social determinants of health, physical and psychological injury to racialized and ethnic communities, especially Black people in the US. And the combination of all these factors, all this health has culminated in health inequities that we see in the United States now. And so the question always comes up, well, how do you measure these things? How do you can't change policy if you don't measure it. It turns out that there are several validated and well-published, as you can see here, indicators of area levels indicators of structural racism. And as I mentioned on the previous picture, these are different aspects of it. It's residential segregation, insurance, and so forth and so forth. I'm going to just focus our attention on residential segregation. As I mentioned earlier, Americans today still live in a highly segregated country, as shown in this map. Most of my neighbors look like me, and that's for most people. That's how it is. And as I mentioned in the beginning, 8 out of 10 major cities in the U.S. are more segregated today than they were 3 decades ago. And again, this determines your access to what kind of school do you go to, what kind of food do you have access to, what toxic chemicals you're breathing when you wake up. And that in turn leads to different health outcomes. This is another snapshot of USRDS data showing the incidence of end-stage kidney disease. And you can see when I overlay this map here, the geographic variation in kidney failure in the United States, to me, tells me that really where you live, and a lot of people really have stated this, that your zip code matters more than your genetic code. Zip code is another title for postal code. So where you matters when it comes to kidney disease, and really with other health outcomes, where you live matters. And that's what I mean by social deprivation. So I wish I could share data with you today about what are the numbers showing in terms of specifically looking at kidney disease outcomes. There are data showing the relationship between structural racism or structural deprivation with cardiovascular disease, with maternal mortality. But it is surprising how little data we have on structural racism and kidney disease, which is where I come in. And sort of what I will be doing the next couple of years, incorporating indicators of structural racism in clinical research at UCSF. So I have 2 research questions that I'm going to hopefully answer in the next couple of years. The first one is, among individuals with established chronic kidney disease, what is the relative importance of structural racism versus APOL1 risk variance in explaining Black and white disparities in kidney disease progression? I have a hypothesis that structural racism matters more than APOL1 risk variance, and I'll see what the data tells me. So to answer this question, I'm going to leverage this study called the Chronic Renal Insufficiency Study, also known as CRIC. This is a nationwide multi-center prospective cohort study of Americans with chronic kidney disease. It's not only the largest CKD study in the US, but in fact, they oversampled individuals who identified as Black. So that allows us to really compare Black and white outcomes. There's some prelim data on the baseline characteristics of CRIC study participants. Mean age was 60 and 44% were female. We had a long follow-up. As we know, CKD is a slowly progressive disease, so this would be important to look at. It started in 2003 and will follow these participants up until 2019. Measurements were obtained annually, so participants come to various CRIC centers to obtain data on kidney disease and other outcomes. Outcome of interest, of course, is kidney failure. And the exposure here, we have two of them, but we're just going to compare, is the area indicators of structural racism that we talked about, so residency and segregation. So in the US, the database is, there are all these public databases that keep track of where people have been living pretty much their entire adult life. And so we can study what kind of neighborhood people grew up, lived in, and assess whether their exposures to these metrics of social deprivation. We're also going to just measure, genotype these individuals for APOL1 risk variants and use this model here, accelerated failure time models, to try to answer which one is more impactful. So that's the first question. The next question is looking at loss of kidney function after kidney donation. So in contrast to individuals with established CKD that we all see when they come to us, we know that for you to be a kidney donor, you have to be absolutely healthy at the time of donation. However, there's some emerging data that suggests that the removal of one kidney is associated with rapid loss of kidney function after donation, especially in the context of APOL1. So here's a graph from Mona Doshi work out of Michigan, that's showing the rates of kidney function decline after kidney donation. So again, this is eGFR on the y-axis. This is time since donation. As you can see here, high-risk APOL1 genotype, so donors carrying two risk alleles that we talked about, have a rapid loss of kidney function when compared with low-risk APOL1 genotype. Now, this is concerning because it would indicate that perhaps we should be thinking twice about obtaining kidneys from people with high-risk APOL1 genotype. However, this is a small, we had about 130 participants, single center study. And so more data is needed to try to really get to the bottom of this. Are people with high risk APOL1 associated with a faster progression of kidney function loss after donation? So that is the question that we are going to answer. And for me specifically, I'm going to, again, just compare what is the contribution of APOL1 risk variants and these indicators of structural racism. To answer this question, we're going to use there's another cohort study that is we're conducting at UCSF called the Living Donor Extended Time Outcomes. This is a nationwide multi-center prospective study. We're currently enrolling Black and white kidney donors, about 1,000 Black donors and 500 white kidney donors who donated back in 2000, between 2000 and 2006. And we're going to, so at the time of donation, this individual had their kidney function measured. You have to do that before kidney donation. And we're going back now at the present time, conducting this home-based research visits to measure their kidney function many years after donation. The outcome of interest here is going to be chronic kidney disease or GFR decline. And again, we're going to use the same exposures. So indicators of structural racism, such as residential segregation, and comparing this with APOL1 risk variance. And this will be a simple logistic regression model. So this is the work that will be doing in the next couple of years. And hopefully next time, if I'm invited back, I can give you data that will either prove my hypothesis about the significance of structural racism or social deprivation versus APOL1. So in conclusion, we know that APOL1 high-risk genotypes are associated with an increased risk of kidney disease among people of recent sub-Saharan African ancestry, but social deprivation is a root cause of Black and white disparities in kidney disease and actually even treatment. And they may be more important than APOL1 risk variance. However, our current focus is mostly on APOL1 risk variance, which may have limited role compared with these social indicators of disease. And we should recognize how structural racism, how social deprivation manifests in our day-to-day clinical work, our research, our policy activities. And to end, I just want to highlight this quote from the great James Baldwin, who was describing or discussing the frustration of lack of progress and lack of equity. So he says, what is it that you want me to reconcile myself to? I was born here in the US almost 60 years ago, and I'm not going to live another 60 years. You always told me it takes time. It's taken my father's time, my mother's time, my uncle's time, my brothers and sisters' time. How much time do you want for your progress? And as a reminder, we've known about these racial disparities for 40 years now, 1970s, for almost 4 decades now, and probably beyond that. This is just the first time it was reported. And so I hope that with time, our generation will advance the progress that James Baldwin is referring to, other individuals of African ancestry who are struggling with diseases sort of across the world. So it's just a quick acknowledgement of my mentoring team, the study participants that I sort of use, and various funding mechanisms. And so, and lastly, the reason why I'm actually in Kenya is just to honor my mother, who passed away about a year ago, and really would just like to honor and thank her for giving this village boy the tools to navigate a very socially deprived world.
Thank you, Dr. Antony Muiru, for the very enlightening talk. I think we have learned quite a lot on the importance of race and genetic code on kidney disease. I think at this point, I can just open the floor for any questions. I think for the panelists, feel free to unmute yourself.
Is there any evidence showing that a recipient's graft survival from Black donors is less than non-Black donors? We know the fact that, graft survival, yes, there are other known factors that does cause graft dysfunction in these patients.
Yes, good question. Yes, so there is data to suggest that Black donors, especially those with high risk APOL1 genotype, have less graft. The recipients have less graft survival, and that's what the pioneer work in that sort of showed that if you take a non-high risk donor and put it in a recipient who's also high risk, there's not a differential there's no differential in graft survival, but so indicating that it's the kidney from the donor with high risk that has higher risk of poor outcomes. So that has been shown in general. The issue though is that these are very small. I guess it sort of depends on what is. We have to be careful about what are we comparing to, right? So if your comparison is dialysis versus transplant, then there's no question that transplant is the way to go. And if you're lucky to have the option of having someone with low risk, APOL1 low risk versus a high risk, then because of this, the differential outcomes, and it makes sense to do the low to obtain a kidney from a low risk donor. But most people don't have that option, right? And again, I think at least in the U.S., there's way too many people who are on dialysis that should be getting transplanted that are not. And so I think we have to, while it is true, yes, there's differential graft survival depending on the donor. We have to be careful about what are the options that we're comparing to. And it's often, if it's dialysis, then any day, then transplant wins. But yeah, but that's a good point.
Thank you very much.
Thank you. Thank you again, Dr. Antony. I've seen Professor Bima. I think his hand is up. Professor Bima, you can just unmute yourself and ask.
Thank you very much, Yuri, for allowing me this talk. And Dr. Muiru, thank you so much for that lovely presentation. APOL1, when it was first introduced, there was a lot of hype about it. And I'm one of those who had a lot of hype about it. So we were seeing a lot of HIV-associated nephropathy. So just to give you a background, my colleague, Professor Sarla Naika, I don't know if she's on the call now, but she did the work in adults and I did the equivalent work in pediatrics because I'm a pediatrician by training. So I'm a pediatric nephrologist, not adult. I must say that when her paper, Kirsten Belli's paper came out, I mean, I was like really taken aback because she showed like, 89% risk for the APOL1 gene and HIV-associated nephropathy. So in pediatrics, of course, as you know, the numbers are much smaller, and I decided that we'll look at it in the pediatric population. And so we studied it not in the large number that she did. I think she did about 80 somewhat patients. So we looked at it in about 30 patients. And I have to admit, we didn't publish the data because the student who did the study refused to publish it without his consent, and he left. So it was an abstract form, but I presented it at the World Congress of Nephrology. And our findings were somewhat counterintuitive. In that, we saw that there was a very low incidence of APOL1 in our pediatric patients who had FSGS, not necessarily collapsing, classical FSGS, but HIV nephropathy. So, I couldn't explain why that was so. And of course, I did this in collaboration with Dr. Cheryl Brinkley at the National Institute of Health. I'm sure familiar with her, right? She did a lot of work on APOL1. So, we couldn't explain this. And it's still an enigma to us why there's this gross disparity between our adults who develop HIV nephropathy as opposed to our children who are developing in this. And so then I took the study a little further, and we decided to look at APOL1 together with the NPHS2 gene mutations in our patients who had primary focal segmental glomerulosclerosis. And initially we did a small study in 30 patients, and then we did a much larger study in about 70 patients. And I must tell you, even with FSGS, in the larger study, there was not a single patient that had an APOL1 mutation. What we found was 39% had NPHS2 mutations of a particular variant. And, that will explain why, for instance, we've noticed that in our FSGS patients who are Black, the response to steroids is very, very low. They have a very low incidence of steroid-sensitive disease. They have much more rapid progression to chronic kidney failure, and that if they have this variation, this gene, they don't respond to, besides steroid, they don't respond to any other immunosuppressive agent. And so we published that, I think it was in the European Journal of Pediatrics, but I must say APOL1 did not come out significant in our pediatric population. Do you have any explanation for this?
Yeah, so I think that is a good question, and I sort of similar to you when we first heard about APOL1 and odds ratio of 89, that is like crazy, So we are all very hyped. So I don't have a good explanation. It is interesting that you did find another genetic variant, and I think in this very specific context of HIV, where you do need that that second hit of just untreated HIV, you don't necessarily need time, right? So, and I'm just sort of trying to explain the difference in pediatric versus adult. So in a non-HIV sort of chronic kidney disease, in the studies I've looked at APOL, FSGS in the context of, say, hypertension, we have seen that it's basically is a time issue. So there are a group of people who will, it's going to manifest later in adults. So it does take time. So it's not very surprising that this non-high-VAN FSGS is not manifesting in adults, in pediatric population. Then there's this survival thing, right? So if you haven't developed it by a certain age, even if you have high risk APOL1, then you're not going to develop. And that's why I think there's much to be discovered of why there's this differential sort of response to APOL1, and why is it that the majority of people with APOL1 do not really get kidney disease, right? So it's very tricky, and I think much more work needs. And I'm glad you published that paper. I'll have to look it up. But yeah, I don't have other than to say that in the concept of non-high-VAN FSGS, it does take time, and we do see this the older, it's mostly an older population type of thing. That, in other words, we don't see, we don't commonly see, and I don't do a lot of things in pediatrics, but we don't see a lot of publications, a lot of information in non-high-VAN FSGS in the pediatric population. But as you pointed out, there are other genetic variants that are important in, especially in the pediatric population. So I think that's sort of how I make sense of your observation.
Yeah, no, thanks for that. And another paper that we just about to publish, and this is not to do with APOL1, was that, it's in congenital nephrotics. So patients develop nephrotic syndrome in the first 3 months of life. So we looked at APOL1 there as well. We didn't expect to find anything, but we just did it because it's, so much of hype about it. And we looked at the NPHS1, NPHS2, etc. And surprisingly enough, as opposed to like the Finnish population, we saw almost just 2 patients out of the number that we studied that had a genetic mutation. So it looks like in our Black population, the NPHS1 in congenital nephrotic syndrome does not seem to play a big role. But I mean, the numbers were small. You don't see congenital nephrotic syndrome as high as what you see in Finland. But I must say, there's the genetic findings are very, very different in Africa as opposed to what you would probably see in overseas. But no, thank you very much for that. As you said, I don't have an explanation. I asked Cheryl and I asked quite a few others, and they didn't have it. I asked Rashid, and he also couldn't explain it. So, but thanks.
Absolutely. I mean, the genetic, and that's why I think H3 Africa and other people have been sort of very important in diversifying and introducing Africans into the genetic sort of studies, because we have a very different.
Thank you. I think there are still a couple of hands that are up. I think Dr. Robert, you can unmute yourself.
Thank you very much, Doctor. First, I want to appreciate Dr. Muiru for such a wonderful presentation, and the organizers for making sure they bring such a great expert to share with us their knowledge. My question is not directly related to what you have presented today. It might be in one way or another, but perhaps a bit deeper. But knowing your experience and some papers I've read about you, really, I'm interested in the way you are now determining kidney function in the US, particularly in Blacks. I know you went through a lot of trouble to see race and economic disparities and whatever disparities are driving the kidney problem. We are increasingly seeing that creatinine, and of course you've read our work, the studies we've done in Malawi, South Africa, and Uganda, showing clearly that creatinine is probably a bad marker for determining kidney function. I saw in one of the papers in which you are a lead author looking at the new formulas in determining kidney function and probably recommending them, particularly the CKDAP 2021. I'd like to pick your brain and also understand what the current status is in determining kidney function across the board, both in blacks and whites. What would be your recommendation? And what would you think we should be looking for in particularly when we are determining kidney function among people of sub-Saharan African origin? I know it's a difficult question, but I just want to pick your brain on it.
Robert, thank you so much. It's so good to see you. And thank you for your question. Yes, I 100% agree with you, and some your work as well. Creatinine is a terrible marker of kidney disease. And I think, unfortunately, across the world, we're just being, nephrologists are married to creatinine for unclear reasons. Because, and this is more of a, personal frustration with our field and lack of innovation. If you compare our field to cardiology, they used to use CK and B to ascertain MIs. And now they have, super sensitive troponin markers. For some reason, we've been stuck with creatinine. And it's not a great marker, especially when you're looking at different population. Example, in some of your work, Robert, in Africa, some of the work we've done with African Americans in terms of the using the race correction factor. So it's not a great marker. Now, the answer to your question is a complicated one because it depends on what is the question at hand. Why do I need to know this person's kidney function? Is it because I want to do drug dosing and therefore I need to be as precise as I can? Is it just to do a epidemiologic sort of analysis, or is it to look at progression? So in the US, what I do, so I'll say that the number one thing we need to do is and everyone on this call who is doing research, we have to continue to look for what are the markers that work best in our settings. That's number one. Currently, what I do, say in clinical practice, is I use a combination of cystatin C and creatinine, especially if it's in the right context, right? If someone who's just a routine follow-up and I want to know what is their kidney function right now. So I think using the combination of cystatin C and creatinine really gives you a very good estimation. Now, there are various clinical indicators that you have to be mindful of, like if you're on steroids, for example, if you're in a state of inflammation and so forth, then cystatin C may not be the best indicator. But I do think generally the combination of cystatin C and creatinine is better than each individual marker, and that's what I do clinically. I think ultimately we really do need to find markers that I imagine will include some urine studies, a panel of biomarkers, sort of like what the hepatologists do with their LFTs. That's what I imagine the future would be. So to answer your question, Robert, I think for me, I use a combination of cystatin C and creatinine because that's what's available. And I would say it's better than each individual marker. The problem is obviously the cost of cystatin C is too high. But I work in the settings that I'm able to do that. But yeah, ultimately is we do need a better marker, sort of what other field have done, the cardiologists and so forth. But thank you for your question. It's a great one. And thank you for the work that you continue to do. I call you the godfather of nephrology in Uganda, in East Africa. So it's great. Great to see you.
Thank you, Dr. Antony, for that response. I've seen Dr. Robert has written on the chat. Thank you. So I'm sure that he's satisfied with the answer. I'm seeing Dr. Ahmed Twahir. I think he has raised his hand. I think Dr. Twahir, you can ask the question.
Okay, thank you, Dr. Muiru, for that very clear and informative presentation. I really enjoyed it, and I'm very proud of you that you're an African involved in very interesting research in California. So mine is just to point out that clearly APOL1 gene seems to be very important, but probably not the only abnormality. Clearly, there are other gene abnormalities, as some of the previous comments have come, that are associated with progression. And I also want to point out that I do a lot of work on diabetic kidney disease, and I'm very familiar with the works of Carl Erik Morgensen, who was typing the natural history of type 1 diabetic kidney disease into hyperfiltration, structural changes, the early diabetic nephropathy with microalbuminuria, and the late with macro, and then end-stage renal disease. And he clearly noted that it takes about 25 to 30 years to develop end-stage renal disease from the time you get microalbuminuria. And we see in our Black population, it takes actually half the time to develop end-stage kidney disease. So our Black patients progress much faster. In fact, there's a phenomenon that I described called the Black kidney, where our Black diabetic patients progress very fast to end-stage renal disease. And one of the postulates that has come about is that Blacks have increased TGF-beta, and this is associated with fibrotic changes. As you can see, the Black skin responds to injury by developing keloids as opposed to the non-Black skin. So what I wanted you to comment is, do you think there's a bigger role apart, as opposed to just APOL1 gene to the progression or the rapid progression of kidney disease in Blacks being contributed by things like TGF-beta? And would it be asking for too much to include this in the study that you're doing in the US with your APOL1 and looking for the social deprivation factors? Would it be also useful to add TGF-beta into your studies? Thank you very much, Dr. Muiru. That's my question.
Awesome, great. Thank you so much. Absolutely. I think I would say that it's 2023, and people have been looking for this genetic variant that would explain the fast progression. And through very excellent researchers, Barry Friedman and a bunch of people in the US have been looking for a long time for this genetic variant and haven't found convincing data outside of APOL1, right? What is the term? The absence of evidence is not whatever the term is. Like, just because we haven't found it, it doesn't mean that it's not there. I have written down the TGF-beta gene. As part of our work, we are looking at APOL1, of course, but also doing a genome-wide, again, looking for some other markers. And I will make a note of TGF-beta and look into this. I would say that if we do find something else, I'd be very surprised. I think that of course, scientific discovery is humbling, and it may be TGF-beta, it may be some other genetic variant. But I don't think so. I don't think so. Of course, I'm approaching the scientific question as a researcher to saying I have my own biases and I have my own hypotheses, but I'm open to being surprised. So absolutely, we can add the CGF. I'll check to see if CGF-beta is part of the variants that we're looking at. Another variant that you just made me think of is APOE, the one for Alzheimer's. There's some data emerging that is also associated with kidney disease. But to find a marker that is highly prevalent in the Black population and associated with rapid progression of kidney disease, I would welcome that, obviously, because that'll be very interesting and it's a point of intervention, but I'd be very surprised to find that. That doesn't mean that we should not look. We will continue looking. But but simply the, if they haven't found it by now, I don't know if we'll find it, but absolutely we'll keep looking. And we go where the science leads us. But I have made a note of this TGF beta, and I'll confirm if we are looking at it already. If not, since we're doing genotyping anyways, it won't be hard to add it on. Thank you for your comment.
Thank you. I think Dr. Wala also has his hands up. I think Dr. Wala, you can unmute and ask.
Thank you very much, Dr. Yuri, Dr. Jonathan Wala from Kenya Renal Association. Thank you, Dr. Muiru, for this elaborate presentation on for L1 and the disparities as concerning Black population in the US. Closer back home, and I'm glad that you're back home, we are experiencing a big influx of dialysis requiring patients. And obviously that's the tip of the iceberg, knowing that chronic kidney disease and all these end-stage disease patients that we are seeing. The Apple L1 story is the classic second hit hypothesis, in that you need a correct genetic background for a particular disease to emerge, being driven by environmental factors. Bearing in mind our population structure, that it's relatively homogeneous, where do you think we should begin investigating? Should we begin with the genetic code or with the postal code for these patients that we are seeing, to explain why we are having so many end-stage disease patients at the moment?
Thank you, Dr. Wala, for that comment and your question. It's a great question. And I would say that, in a world of unlimited resources where we can just study whatever we want, we should look at both genotyping people and looking at the social indicators of disease. But if you're limited, I would say that, again, I don't want my comment to be interpreted as I'm not saying genetics is important. It's not important. It is. But I would doubt that is what's driving the explosion that we're seeing of kidney failure. I think we need to look, again, in a world of unlimited resources, yes, we should look at genetics. But if we are limited in what we can do, I think we have to first, number one, look at what are the truly risk factors of kidney disease much earlier on. Some of the work I'm doing in Uganda and Kenya is looking at this question. We published a study for 3 years of 2020 that showed that people with early kidney disease, with albuminuria and a low GFR, a good proportion of them do not have this so-called traditional risk factors, don't have the diabetes, don't have the hypertension, don't have the HIV. So much of what you're seeing clinically, of course, by the time they come, they may already have high blood pressure, and it may be a bit too late to tell what is the etiology of the kidney failure. So I think if we were to be strategic about where we put our limited resources, I would say we have to go much further out, create these prospective cohort studies and follow people. This is what the Americans did with the Framingham study and other sort of cohort to try to understand what are the risk factors for disease. So I would say that good old epidemiology studies, especially going really upstream for younger people before they develop kidney failure, using the available markers, whether it's creatinine, whether it's cystatin, albuminuria with dipstick, and really trying to get at the question, what are the risk factors? And then I think we can go from there. But I would say that if we were to put our eggs in this genetic basket, we may, I'm sure, I don't know, again, it's science, we'll see, but I would say that if we look at other population, that's not where the money is. It's really on trying to understand what is the actual risk factor, whether it's some other exposures, social indicators, whatever it is. I think that's what I would say the money is, and less so more on the genetic background. That being said, we should definitely collaborate with things like H3 Africa and other people doing genetic work to try to make sure that we Africans are represented in these genetic studies. But I think if you push me and say what do I want to study, I would look for trying really to understand the epidemiology. These people who are the explosion of kidney disease, why is that? What are the risk factors? And I don't think that we actually know that just yet in our population.
Thank you,
Yes.
Dr. Muiru. I know it's quite an interesting topic because it has generated quite a number of questions. I hope you have a bit of time just to take a few more questions from the chat box. Maybe I can just start with one that's related to screening from Mazar. I think question is, what is your opinion in the screening, in terms of screening the population for the APOL1? Probably might not be feasible because of the cost, but the benefit will follow up closely to prevent incident and progression of CKD. I think second part of the question has been asked in relation to that by Dr. Lloyd, that in the US are APOL1 risk variants routinely assessed for in live donors from the Black population. So maybe you can tackle the two at the same time.
Yes, I'll tackle the US question one because it's easier. So it's not, so right now, our APOL1 risk variants routinely assessed in live donors. So some centers, so there's so many transplant centers in the country because it's so big. There are some centers who are genotyping potential donors and using that as part of their risk assessment for risk of kidney failure after donation. There's no consensus just yet. The Apollo study, which we or my colleagues are involved in at UCSF, is really hopefully going to be published soon and will give us some more data-driven guidelines on whether we should be routinely assessing APOL1 in a donor population. Of course, the concern is this: if you as we mentioned, as Dr. Waller pointed out, this is a two-hit hypothesis. It doesn't mean that just because you have a high risk APOL1 that you will develop kidney disease, right? So if you instituted a policy where you don't obtain kidneys from high-risk APOL1 donors, you can imagine, and yes, families donate to family members, friends donate to friends, right? So if you're excluding 13% of potential donors, that can be a huge problem. And that's why I think the study would be very informative and looking forward. They just finished enrolling, so we'll see what the findings show. On the other hand, if it's true that once you donate a kidney, if you're high risk and you donate a kidney, that you lose kidney function faster, if that is a true statement, then it will be, do no harm, right? It would be beneficial to not obtain that kidney, right? So it's such a complicated issue that unfortunately some people are starting to do this without having enough prospective, rigorous data to guide them, which I think it's, the programs sort of make their own decisions. But I think once this data comes out, we'll be able to proceed with the consensus guideline. In terms of the question specifically in East Africa, I think whether screening for APOL1 is necessary. Again, sort of thinking about resources, the epidemiology, I haven't seen actually a lot of studies from Tanzania, but if you look all of the countries around Tanzania, Ethiopia, Kenya, Uganda, and some of this work that we have done should be published soon. The distribution of APOL1 is very low. High, like I'm talking about 1%. So therefore, I would imagine the sort of wide screening is probably not necessary. And I'm making a sort of reach here to say, if I'm in Kenya, if I'm in Western Kenya, where some of our data are, if I was practicing in Western Kenya, I would not genotype someone for APOL1, just given the pretest probability is so low and the cost of that test. But from an epidemiology standpoint, yeah, we should do that and try to better document this disease. But for screening purposes, I don't think it's necessary. At least the data so far do not point towards APOL1 being a significant contributor of kidney disease burden in East Africa. Different question in Ghana or Nigeria and so forth. Very high frequencies. So that would be a different place.
Thank you so much.
Thank you, Dr. Antony Muiru, for the very enlightening talk and for creating time, at least, to have this presentation today. We look forward in future to have you, I think, for more talks and for more discussions. And on behalf of Africa Healthcare Network and our panelists, I want to just convey my thank yous and wish to see you soon in the future discussions. And thank you again. And think I'll give the closing remarks to Dr. Lloyd.
Thank you, Dr. Muiru. It was a wonderful session. And I think the issue of structural racism, I think that is a very, very important point and actually needs policy changes. And I think that accounts for the large number of, dialysis, large numbers of the dialysis population that we actually find not only in the US, but probably in the developing world as well. And the diabetes, the hypertension, the NCDs, probably it's to a great extent, due to this structural, racism that comes on. So thank you very much for highlighting that, and it's actually a great eye opener. And wish you all the best in all that you're doing. And we really hope that you would come more frequently and interact with East Africa much more, since you're a son of the soil as well. Thank you very much. I'm grateful for today's excellent presentation.